So welcome everyone, very warm welcome from the Global Health Network and the Oxford University Global Surgery Group. My name's Helena Wilcox and I'm from the Global Health Network, and I'll be facilitating the session today. I'm really pleased to be joined by Professor Kokila Lakhoo from the Oxford University Global Surgery Group and by Dr Anita Makins, who will both be speaking today. I'll just spend a couple of minutes introducing the session and then I'll pass over to our speakers to really focus on what they're going to be sharing today. So this lecture is brought to you, as I said, by the Global Health Network and the Oxford University Global Surgery Group. This is part of the Global Health Network's Global Health Research in Focus lecture series, and you can find out more about this series on the URL that you'll be able to see on the screen. The discussion today will focus on ensuring global access to surgery, in particular during pandemics and of course in COVID-19. If you'd like to find out more about the work of the Oxford University Global Surgery Group, you can see their Twitter handle on the screen, so please do go and find out more about their work. So to introduce the session today, I'll just kind of go through some of the themes that will be touched upon today. So in 2015, the Lancet Commission on Global Surgery found that treatment for surgical conditions across a broad range of diseases represents approximately 30% of the global burden of disease, spanning 100% of disease subcategories, and it remains out of reach for the majority of the world's populations. This is resulting in loss of life and reduced welfare for millions of people, also stunting economic development. The Oxford University Global Surgery Group is part of a worldwide movement helping to ensure at least 1 billion additional people get access to safe and essential surgery by 2030. And they're doing this in a few ways. Firstly, by promoting, advocating for and advising on best practice in global surgery, particularly on research and training. Secondly, by working closely and under local guidance of colleagues in lower middle income countries. And thirdly, providing a forum for networking between those actively engaged in and those seeking opportunities in global surgery. And Kokila in particular during her talk will go into much more detail and share more about the extensive work of the group during her talk. I'll just spend a couple of minutes introducing both of our speakers today. So our first speaker will be Professor Kokila Lakhoo, a consultant paediatric surgeon at the Children's Hospital in Oxford and the University of Oxford. She recently received an honorary professorship from the University of Witwatersrand in Johannesburg, Muhimbili University in Tanzania. She's director of the Global Surgery course for Oxford University and represents Oxford University for Children's Global Surgery Matters. She's the chair of the International Forum for the British Association of Paediatric Surgeons and is personally developing paediatric surgery through a link between Tanzania, Malawi and South Africa. She's the president of Global Initiative for Children's Surgery that has followed on from the Lancet Commission that I mentioned in the introduction. She's also the editor of 4 books, including a recent joint venture with African colleagues as editor to a book named Paediatric Surgery, a Comprehensive Text for Africa. I'd like to introduce now our second speaker, Dr Anita Makins, Fellow of the Royal College of Obstetricians and Gynecologists and with a Master's in Public Health in Developing Countries. She's a consultant at the Oxford University Hospitals Trust and honorary senior lecturer in global women's health at the Nuffield Department of Women's and Reproductive Health at Oxford University. She has extensive experience in sub-Saharan Africa and is currently director of the PPIUD initiative at the International Federation of Obstetricians and Gynecologists, which is a project running for 6 years across 6 countries in Africa and Southeast Asia. So to begin our session today will be Professor Lakhoo, who will share the work of the Oxford University Global Surgery Group, focusing on working towards global equity in surgery worldwide. And then following from that, Dr Makins will discuss the impact of pandemics on women's health, in particular in lower middle income countries, and of course, touching on the impact of COVID-19. So I'm now delighted to pass over to Professor Kokila Lakhoo for the first talk. So thank you so much for joining us, Kokila.
Thank you very much for that kind introduction. Oxford University Global Surgery Group is made up of 4 departments, and the 4 departments are there at the bottom of the slides. What we're doing is working towards equity in surgery worldwide. And how did all of this come about? You will hear as I continue my talk. But I'd like you to draw your attention to the picture on my slide. If you look at the picture, this is a children's surgical group in Tanzania. And the workforce there is in this format, that all the surgeons in the children's surgical group are women. All the scrub team are men. The anesthetic group are a mixture of nurse anesthesia and doctor anesthesias, but a mixed gender. And the students and trainees are equal. So, you know, a place like Tanzania, which is probably the second lowest country in terms of economic GDP, doesn't need Athena Swan, it's already there. So global surgery, where has that come about? Now, global health has been around for a long, long time. And we are the new kids on the block, in that a lot of work that has been done is related to communicable diseases such as HIV, malaria, TB. And in 2015, the Lancet Commission came on board to look at the non-communicable diseases such as surgery, and where does surgery fit in? In the work that they've done, they came about with key messages, and a group of financiers, economists, doctors, nurses, allied health workers put this together in the literature search and in the work that they put together. And they came up with a figure that 5 billion people of the 7 billion people around the world lack access to surgical care. And HIV, tuberculosis, and malaria combined have less deaths than road traffic accidents. Other messages that came across from the Lancet Commission was that quite a large number of surgical procedures are needed in low and middle income countries each year. Also, families go into poverty due to the catastrophic expenditure required for their loved ones to get the surgical care. But investing in surgery is affordable and saves lives. In the Lancet Commission, they formed this workforce group called the SOA, made up of surgeons, obstetricians, and anesthesia. And the conclusion from the 5th message was that it is an indivisible, indispensable part of healthcare. And why is that so? Because if you look at the cost of surgical expansion for what is required between 2015 and 2030, that's the amount of money that's needed. But if you do not invest in surgery, then the total GDP losses around the world will be that much. So in the Global Surgery Group at Oxford University, we are a group of researchers, and we've collaborated, combined with many countries for many, many years, but all in our individual basis or in our departmental basis. And we've sort of put ourselves all together under the Global Surgery Group. And we found that we have over 100 countries that we have collaboration with, or some sort of input in terms of training, research, and many other. And it's spanning across the world. And we have multiple projects. When we did put our numbers together, we were surprised at how much from the Oxford University Global Surgery Group it's going out there without being recorded. We have 4 leads from the 4 departments so that we can coordinate ourselves. Anita Makins is the lead for women and reproductive health, and you will hear about that after my talk. The next leader is from anesthesia, which is Hilary Edgecombe. And in the anesthetic department that Hilary is leading, a lot of work is going into developing safe anesthesia in low and middle income countries. And also there's, at the moment, some work going on to developing an app for neonatal surgery. What I did forget to mention that Anita's work at the moment is concentrated a lot with Figo, which she will mention in her talk. Chris Larvey, who leads the ENDOMS, which is the orthopedic team, is well known in Africa in many countries. He was one of the founding members of the College of Surgeons of East Central and Southern Africa. But in the past 2 years, he spent a lot of his energies developing a hospital for children in Zimbabwe. My work has been related to many organizations, but recently, as was mentioned, that when the Lancet Commission came about, they forgot about children. And it always happens that children get forgotten from the surgical group. So during the launch, I approached some of the leaders to say that, what about children? Because in low and middle income countries, 50% of the population, or almost 50%, and in some countries over 50% of the population are under 18 years of age. And I was told in no uncertain terms that if you are the children's advocate, why don't you get on with it? So with a few interested people, we formed the Global Initiative for Children's Surgery, which I would liken as sort of the UNICEF for children's surgery. So in Oxford, we recently, during the COVID pandemic, realized that there's a lot of work in which children are neglected when it comes to surgical needs. So we formed a group called Global Children's Non-Communicable Disease, which is just one aspect of our Oxford University Global Surgery Group. And what we've done is we've picked 3 big areas where there's a big need. And why did we choose children? Because over 2 billion children have no access to surgery out of the 5 billion. And also 85% of children will need some sort of surgical intervention before their 18th birthday, be it a tooth extraction. So our first COVID work that we've been doing is the MultiCenter International Collaborative Study, looking at what has happened to cancer kids during this COVID pandemic. Now, you must have heard in a lot in the media and in publications that children haven't really been affected directly by the virus, but they are collateral victims of the virus, and a large proportions of our children have died due to collateral damage rather than the primary viral infection. So we are looking at what has happened to children with cancer, with our primary objective being 30-day and 90-day all-cause mortality. We've found that when we put this out there, the reason for doing this was that there was a call from our LMIC colleagues that, look, our chemotherapy has stopped, though limited. Our cancer kids have all been sent home because of the pandemic, and children with cancer who are partly treated have not completed their treatment. So we needed to get the figures for these. We have our secondary outcomes that you can see on the slide. Within 2 weeks of our launch, we had 100 countries sign up, and about 2 weeks ago, we've had 502 centers recruited, 690 cases uploaded, and a large number of collaborators. A lot of the work is still ongoing because the IRB in many of the countries haven't come through yet, and it slowly are marching along. But just from about 30% of the IRBs, we have 690 cases loaded. The steering committees, as you see out there, Newell Peters and SOAM have done a lot of the groundwork, and a lot of our students during the COVID period has assisted us as part of the operation team. We also have this ethos of embracing our LMIC colleagues and encouraging them when they're successfully able to get their IRBs and move forward. And we are providing research seminars and research teaching for all our collaborators at whatever level that they require, be it a case report or a large multi-center study or a systems work. One of the studies that was already done by one of our colleagues, Roba Kunkar and Soham, is looking at the impact of COVID-19 on healthcare workers. And this paper has just been accepted by the BMJ. We are not just a surgical team. We have geopoliticians, we have geographers, and we also have public health workers working with us so that we don't only look within the theater, but are looking outside the theater as well. Anand Jani is one of our greatest advocates who works with us and constantly reminds us that it's not just what happens in the theater, but what happens outside. And I'd like to take just a few seconds to read that quote from him, which is so important, that we are concentrating on what's happening now, but what's happening outside of this time, it's going to be even harder, but yet it's not impossible. So I'd like to thank Anand in the sense that he's always with us and reminding us that theater is not the only place that you need to look at in global surgery. We also looked at work in children in Africa. And again, as I mentioned earlier, that children have always been collateral damage rather than actual sufferers from COVID-19. And during the high pandemic in April, when a lot of the Western countries were affected, such as Italy, Spain, UK, USA, a lot of concentration on trying to control this was happening at tertiary levels with ventilators and hospitals and tertiary care input. And in Global Initiative for Children's Surgery, we wrote a letter to the editor of the World Journal of Surgery to say that we should look at South and Eastern countries, our low and middle income countries in those hemispheres of the world, because they have experience with these pandemics and are working at primary healthcare level rather than at tertiary healthcare level. They've gone through HIV, TB, and many other pandemics and have started at community level rather than at tertiary level. And just recently, a talk by the president of COSEXA, Professor Godfrey Mnguti, mentioned the successes in Africa in controlling COVID, which was the biggest fear of the UN, that if it's affecting high-income countries now, what will happen when COVID goes to Africa? But I think Africa has challenged that and proven themselves that it can be done without much resources, but concentrate on primary healthcare level. Research work that Hilary from Anesthesia is putting in is that just recently she's been a co-editor of a book on global anesthesia, and he's been working quite hard with a group of researchers on task sharing and training for non-physicians in anesthesia, looking at perioperative care, and then working with Mike English's group on developing a mobile app on resuscitation, and working quite well with a large number of clinical fellows on global anesthesia in Oxford. Chris Lavey's recent work has been with Surge Africa. Surge Africa is a European Union funded project where they were looking at strengthening surgery in district hospitals in Tanzania, Malawi, and Zambia. In the NDS, we've had quite a few projects rolling. Few of them that I'd like to mention is the one on surgical decision-making around pediatric preoperative anemia in low and middle income countries. Now, we embarked on this study because in low and middle income countries, a large number of our children get canceled because the hemoglobin is supposed to be low, or it might be low, or it may be low. So with one of our academic fellows, we did a literature review, which the Lancet enjoyed, and looked at how we can establish maybe a protocol or some sort of guidance together with our LMIC colleagues in Bangladesh and Tanzania. So this came driven through people from Bangladesh and Tanzania saying that we want to avoid these cancellations on the day of the operations because it's not cost effective and not helpful for the families. So we've completed phase 1. We started phase 2, which has been kind of in a wobbly state because of COVID-19, so we couldn't continue, but have restarted the project. And then in phase 3, we're going to look at the transfusion practice post our protocol. We also did work with Mike English and his team regarding neonatal work. So the story goes that I was very interested in Mike's team from Kenya, who were a large number of pediatricians working in the district general hospitals. And what I wanted to know is that how many of the babies that they are looking after have birth defects that are surgically correctable. And we approached the team to say, would they like to work together on the project? And they came back with to us to say, look, no, we want to look at neonatal pain and not the birth defects from a surgical perspective. So with another of our academic fellows, Ken Wade, we embarked on the project that they wanted support and assistance for. And again, the Lancet did enjoy that. What we did find is we developed locally relevant clinical guidelines for procedure-related neonatal analgesic practice. And what is quite interesting in this paper is that we came up with an evidence through our systematic review and meta-analysis. But when we presented this at the local conferences, we realized that in practical terms, some of those answers from our research were not practical. So we had to change the structure and the modus operandi to what was relevant for the country. We have done other quality improvement work, which you can see on the screen. Regarding research in multi-speciality, we have a wide-ranging work process. There's some work on birth defects in many countries regarding anorectal malformations in newborns. We looked at pediatric trauma from a multi-country perspective. And there's been some work on looking at primary trauma care courses in sub-Saharan Africa. From an advocacy point of view, the Global Initiative for Children's Surgery published where we had come to, and we had produced a blueprint for anybody that wishes to provide surgical care for children, including anesthesia and perioperative care, were they plastic surgeons or cardiac surgeons, or if they wish to establish a palliative center for surgical children. We had over 300 of our LMIC colleagues that had put out this document with evidence and guidance. We also have been advocating in many of the conferences that global surgery is important and shouldn't be forgotten in any of our surgical specialties. Further on global surgery education, we feel very strongly that we need to now develop fellowships in global surgery, and we put out our thoughts in the International Journal of Surgery. And similarly, we felt that in children's surgery, training a group of a surgical team in the district general hospital to do basic children's surgery would assist development of this and release the tertiary centers of the high burden. And basically, the surgical team would include an anesthetist, a surgeon, orthopedic surgeon, theater, and ward nurses from an adult team learning to develop work with children. The workforce issue has always been discussed at any global meeting, that the workforce in low-income countries is low and difficult, and life expectancies all relate to the outcomes from the amount of workforce that one has. What was interesting in this slide is this work that was done showed that, yes, workforce numbers are very low and middle income countries, in the gray dots, and that when you get to high income countries, the workforce is high. But if you want to look at the ideal target for the number of workforce per 100,000 people, it's very clear that if you take the figure 40 workforce per 100,000 population, anything more than that doesn't really make a difference in life expectancy. So 40 per 100,000 is actually the safe figure for the workforce. Coming to teaching and training in global surgery, many of us have been involved in the exams for COSEXA. My colleagues Ashok Handa and Tony Jeffries have been running leadership courses in many countries, but focusing mainly on Kenya. And through the British Association of Paediatric Surgeons, we've been running neonatal skills course for surgeons, for adult surgeons, to do basic surgery so that these little babies can have their primary operations and then be transferred to tertiary centers. We have also been training surgically minded pediatric surgeons in skills for neonatal surgery, because that is an area where we have the largest number of deaths in surgery. This is something that I've worked on for a long, long time, and it's something I'm most proud of, that I've established a Tanzania Oxford Children's Surgery collaboration. It's over 17 years partnership. And through this partnerships, with no pediatric surgical input in a country, we now have 4 established centers that are running departments with fully established theaters donated by Kids OR, and our training fellows that have now joined the COSEXA training group. We also have moved on just from clinical training and teaching. We've now employed a researcher locally in Tanzania who's now has got 3 funded projects that he's working on. And we've also delved into technical development, in that one of our PhD students and registrars in general surgery is looking at point care ultrasound for surgery in adults and children. And we've also looked at low-cost simulators that we've worked on, costing about $5 compared to $2,000 of the ones that we use in the high-income countries. We've done work in teaching and training conflict zones, and for many, many years, my colleague Nick Maynard and Tony Jeffries have been doing medical school training in Gaza, and another colleague is beginning to develop undergraduate syllabus and curriculum for our new country in Southern Sudan, with the university based in Juba. Some of our colleagues are working in disaster area together with Mercyship. One of our colleagues, Roba Kunkar, has done a lot of work with our SSM students and stimulate a whole group of students into global surgery. And they've had posters presented at many, many conferences. The undergraduate education is a concept that I just want to briefly talk about, which is Oxplore. And Oxplore is a concept of Oxford students going on an elective in different parts of the world, mainly in LMICs. And what we've done is we've linked them with a project that they need to do. So when they did do this, they, when we developed the concept, they won a prize at one of the pediatric meetings. And we've had 2 projects now over 2 years, one on tumors in children and another one on looking at the WHO checklist. We also run a credit-bearing short postgraduate course with 20 CAT points, and hoping that that will soon become part of a master's program embedded with the medical department. I'd like to thank Roba Kunkar for a few of her slides, and thank the entire Oxford University Global Surgery Group for their input in all the work that I've presented on their behalf. Thank you very much.
Thank you so much. It's so fantastic to see both the breadth and the depth of the work that the group are doing, and thank you for sharing on behalf of your colleagues too. I'd like to move swiftly on so that we have some time for Q&A at the end, and introduce Anita, and for you to share your presentation on specifically on the women's health aspect of some of the group's work. So thank you very much, Anita.
Right, so good morning, good afternoon, or good evening, depending on where you are in the world, and thank you so much for the invitation to talk today. I'm just going to be talking generally really about women's health in low middle income countries during this COVID-19 pandemic. And as has been mentioned, I work here in Oxford, but I also work for Figo, the International Federation of Obstetricians and Gynecologists, and by trade that's what I am. I'm an obstetrician and gynecologist. So the COVID-19 pandemic, as everybody is well aware of, started at the beginning of the year, you know, an absolute surprise, and it's just spread around the world. There are now 37 million cases worldwide, with over 1 million deaths recorded, and it's pretty much affecting, you know, every single country around the world. The Americas currently have the highest cumulative number of reported cases, but Southeast Asia is rapidly going up. In Europe, we now seem to be getting sort of second wave, it's being called. So really huge implications globally. So in terms of women's health, how is COVID-19 affecting women's health? So two ways really. Firstly, could be by direct effects, so direct deaths from COVID infections, and secondly, the indirect effects. So we talk about the 3 delays in particular in obstetric care. So the delay to seek care, the delay to actually reaching care once somebody's decided they want to go to hospital, and then the third delay is the delay in the hospital once they arrive there, or in the health centre. And COVID-19 really has made all of those 3 delays even more enhanced. And then the other indirect effects would be related to unplanned pregnancies due to the lack of access to contraception, and hand in hand with that are unfortunately a number of unsafe abortions, which also cause maternal morbidity and mortality. So if we think about the direct effects, well, we've been quite fortunate in the sense that it doesn't seem like the outcomes for pregnant women who contract COVID-19 are worse really than their adult counterparts, non-pregnant adult counterparts. So the biggest series, I think, is this one produced by Marian Knight. So this is the surveillance survey here in the UK. So she looked at 427 cases, and of those, 1% of them died, 93% of them were discharged well, and then over the period of time she was looking at, 6% were still in hospital. And of those, in terms of their treatment, so 10% needed critical care, only 1% needed extracorporeal membrane oxygenation, and 24% of them had pneumonia. So on the whole, sort of a bit like Kokila was saying, really, that the direct effects of COVID are not the issue. What's much more of a concern are the indirect effects. So in terms of the indirect effects, this is a table, or it was a report published by the Guttmacher Institute. So these authors are from the Guttmacher Institute, and they would try to predict really what would happen in terms of women's health care if there's a decline in contraception, which is likely. So if there's a disruption in essential sexual and reproductive health, and you can see there on the left-hand side, if there's a 10% decline in the use of short and long-acting reversible contraceptives, we're expecting 48.5 million additional women with an unmet need for contraception. So that's a lady who's of a reproductive age, who is sexually active and wants to use contraception and would not have access to contraception. So this would result probably in 15.5 million unintended pregnancies. If there's a 10% decline in service coverage of essential pregnancy-related and newborn care, then we'd be expecting an additional nearly 2 million additional women having obstetric complications without having access to care, 28,000 maternal deaths, 2.5 million newborns experiencing major complications without care, and 168,000 additional newborn deaths. So huge numbers really in terms of the direct impact on access to care. And then lastly, if there's a 10% shift in abortions from safe to unsafe, which is likely to happen, you'll end up with over 3 million additional unsafe abortions and the maternal deaths that follow with that. So the indirect effects of the COVID-19 pandemic are far more of an issue than the direct effects. To give you an example of one country that I work with closely through Figo is Bangladesh. So the two graphs here are showing you a comparison between March to May in 2019, which is the blue columns, to March to May in 2020, which is the orange. And you can see there on the left, you've got the oral contraceptive pill reduced by 20% in terms of uptake, condom use by 34%, the injectables down by 23%. And then the table, the graph on the right, is looking at long-acting reversible contraceptives, which unfortunately have dipped even more. And actually, these are the ones that we would want to be promoting during the COVID-19 pandemic because they're long-acting, and so people don't need to keep coming back for supplies. You can see there the intrauterine device dropped by 26%, the implant by 25%, vasectomy 64%, and tubectomy, so bilateral tubal ligation, by 60%. In Bangladesh in particular, women stopped coming to hospital to give birth and went for home births instead. So they were missing out on quite a few of the surgical procedures that could have been done at the time of birth, like tubal ligation or IUD insertion. So the estimate by UNICEF is that there will be 2.4 million babies born in Bangladesh under the shadow of the COVID-19 pandemic. So for many low middle income countries, the issue is going to be the burden of disease related to this huge number of unplanned pregnancies. So just, I find this paper interesting. It's an observational study that was done in Turkey. It was published in the IJGO just recently, and it was looking really at people's sexual habits before and after the pandemic. So just by coincidence, they were doing this telephone interviews before the pandemic, so 6 to 12 months before the pandemic. And you can see there the frequency of sexual intercourse per week significantly increased, doubled actually, when you compare during the pandemic to before the pandemic. Desire to become pregnant dropped from 32% to 5.1%, but the use of contraception drops from 41% to 17%. So if people are more sexually active, but there's less contraception around, then that is going to result in unwanted pregnancy. So the big issue. So you may wonder why I've got a picture of Churchill here. Well, because he said something that I think is highly relevant actually for the COVID pandemic, which is after the Second World War, when they were putting together the UN, so negotiating the formation of the United Nations, he said, never let a good crisis go to waste. And I think that's exactly true of what's happening now. So there are many positive things that could arise from the pandemic. And I hope to outline a few of these on the slides to come, because I think it's important that rather than just getting very depressed about all the terrible things that are going on, which no doubt, world recession and all the rest of it, but there are things that we have been pushed to do that could improve our practice and our care for women's health. So firstly, decentralisation. So one thing that was definitely very noticeable here in Oxford was how much more efficient we could become as a hospital, and when there was a degree of decentralisation, when we were able to make our own decisions about, for example, which patients we were going to see face to face, or which patients we were going to see on the phone, or just lots of little examples how decentralisation made our practice more efficient. And I think that's true on a global scale in many respects. So transparent sharing of information at the local level regarding several things like the mechanism of transmission of the disease, the local epidemiology, being truthful and honest about provision of PPE. It's not so much of an issue now and in many countries, but at the start it really was. And so it's important that healthcare workers are empowered to be able to make informed decisions about how they can best continue to provide the services that they want to provide, but in a safe environment. And if it means, you know, thinking laterally or outside the box or using mechanisms that normally we wouldn't do, then maybe that should be the case. And so the pictures here, you've got a lady actually in Manaus, the capital city of the Amazon in Brazil, making PPE for the local hospital. And then on the right there, you've got a Mozambican in the market with his homemade face coverings, I should say. Secondly, working in partnerships with communities. I mean, this is something, if you listen to the WHO Director General's weekly or twice weekly press conference, he's been repeatedly saying that it should be an all-country response and that community involvement is absolutely key. This is a photo of a health centre that I worked in Mozambique, and you can see there the people in the white are the official healthcare providers in that health centre, but actually all the other people that are on the photo were also intensively working in the health centre, but they were community members of the community who were there for various reasons, whether they were traditional birth attendants or whether they were community health volunteers. And I think their involvement is key actually in keeping on top of the situation. I think Kokila mentioned briefly, you know, how well Africa had done, and I think, as she said, you know, there's no doubt that certainly sub-Saharan Africa, but many low middle income countries are more used to dealing with infectious diseases, but they also have very well established structures where they deal with their communities, and high income countries don't have that, and so in that sense we've got a lot to learn. I think it's been an opportunity for trying to consider healthcare in more of a holistic and integrated way. So in my field, the obstetric encounter, so when women actually come to hospital or to a health centre to give birth, has become a golden opportunity to offer all kinds of healthcare that the woman otherwise would not get. Contraception being the obvious one, which I've mentioned already. So I'm talking really about postpartum family planning. So I've worked for many years with Figo on trying to expand postpartum family planning, but the COVID pandemic actually has made it even more important. So when women come to give birth, it's not just about coming in, giving birth and going home, but we should be thinking of all the other things that they need to access so that we can then keep them out of hospital, so they're not coming, you know, to receive contraception 6 weeks down the line, but actually they leave hospital with it. And there's several other examples where we can think about immunizations and so on, other opportunities where people seek healthcare, but actually they could get so much more from us if we weren't sort of focused on our one little job in front of us. And just to mention, the long-acting reversible contraceptives is particularly useful at the time of the pandemic. So the copper IUD and the intrauterine system, so the hormone-filled coil, it's not available in many low middle-income countries, but the copper coil does even a better job, I would say, in that you can keep it in for up to 10 years. And this means a lady doesn't have to come back for contraception, but again, it can easily be taken out if she changes her mind. So reversible but effective contraception. Self-administration methods are important, and they should be actively promoted. So rather than giving people just their, you know, pill for a month, give them large supplies, more than 6 months, so they don't have to come back. Need to be thinking about other ways of making it accessible, so emergency contraception by post, for example. When we're talking about depot injections, so we can be using subcut medroxyprogesterone acetate injections rather than the IM, which means that people can self-administer. But we're starting to do that here in Oxford, and I know something like Cyanopress has been available for a long time in many LMICs. Vaginal contraceptive rings are another example, but we can extrapolate this to all kinds of other care that we give. For example, women doing their own blood pressure at home, if they're being under surveillance for preeclampsia, etc. Removal of barriers. So we have certainly in women's healthcare, lots of things that we do in a particular way because we've been doing that for years, and therefore we don't change it. And actually what the COVID-19 pandemic has made us think, actually, do we really need to be doing it that way? So simplifying processes, decentralizing the services so that they're more accessible to all women. Task shifting and task sharing is something that the WHO has been talking about for a long time. You know, so are there things that doctors routinely do, like, for example, contraception and insertion of postpartum IUDs or IUSs? Is that something actually that a nurse or a midwife be counselling on contraception? And the picture on the right here are some midwives who I worked with in West Bengal in India and in Kalyani, and I used to call them the super nurses, because when they learned how to insert the postpartum IUD, the access to them just went sky high, and something like 1 in 2 ladies leaving the hospital had this IUD in situ because suddenly, you know, the midwives and the nurses were on board and doing a task that previously had been only done by doctors. And then lastly, better use of pharmacists. So can there be more over-the-counter prescription? You know, what does it say? There are many things that are very safe to give over the counter that would mean that people do not have to come into hospital to receive the healthcare that they need. Telemedicine, using it at every opportunity. So there are many pilot interventions in LMICs using telemedicine. Well, these need to be put in practice, whether it's just a simple telephone appointment to give advice, or whether it's more complicated things using Zoom and Teams and Skype where a computer's necessary. You could have call centers that people ring into. Social media these days gives a huge amount of information to a large number of people. And thinking also of home delivery of different items and goods. The other thing it highlighted, or what became evidence, was that it was an opportunity to collaborate even more against sort of various multilateral agencies or NGOs that work in different countries, you know, collaborating with governments, etc., but unifying that collaboration. So UNFPA supplies contraceptive methods to more than 46 low and middle income countries. And what happened at the start of the pandemic was that they ran into huge difficulty with keeping those supplies going because there were issues with the shipment of components from China when the first lockdown happened in China. There were issues with when the lockdown happened in India in terms of actually producing the methods. And then there were issues with transborder transport between countries. And so this interagency platform was created where UNFPA was constantly coming with their COVID-19 updates, I think on a quarterly basis, actually pinpointing which countries were going to be running out of which types of products. And so that NGOs could coordinate themselves and governments could organize themselves to move supplies around to ensure that there weren't stockouts. And you can see the top is about contraceptives, but the bottom of the table is about absolutely life-saving medicines like oxytocin, misoprostol, magnesium sulfate for eclampsia, etc. So these are all things that previously were being supplied by one agency. And what it also brought to the forefront was the fact that actually there are serious issues with the way family planning is financed around the world. This pie chart is just looking at the supplies of contraception and who's funding them. And you can see there that 28% of contraceptive funding for low-income countries comes from USAID, 28% from UNFPA, and you can see there 5% other donors, 10% government-managed donor funds, and 4% NGOs. And so actually 23% are private sector, but only 2% is the domestic government supplying contraception in these low-income countries. And that's just a very worrying state of affairs, because basically the countries are relying on external funds which are not absolute. And so when there was the issues with the defunding of some of the agencies that USAID or the NGOs that USAID was funding, then you've just suddenly lost your supply. So governments really need to step up to funding their own contraceptive methods and keep to the 15% budget which was agreed at the Abuja Declaration, because otherwise we're in a very, very precarious situation. So lastly, sorry to talk too much, this is my concluding slide. So low-middle-income countries, for most of them, some of the things that I've talked about are actually the norm. So infectious outbreaks and emergencies are the norm, and therefore, in a way, LMICs are almost better equipped than many of the high-income countries, and that's an opportunity for sort of south to north learning. It was recently, again, on one of the WHO press conference, a chap from Francophone West Africa talking about how they got on top of their Ebola outbreak in Congo just by using, you know, basic public health, contacting, tracing and isolating, which some of the high-income countries have found so hard to do during this pandemic. That LMICs are very often well equipped or used to doing task shifting and task sharing, that community health workers are the norm and that they can be part of this testing and tracing system. Talked about self-administration methods, to say also that innovation and flexibility are common traits in LMICs. An example is in Bangladesh, the TB gene expert machines were converted, or stations even were converted, to COVID-19 testing hubs around the country so that the population could quickly be tested if they became symptomatic. So all on the whole, very positive. So that's the end of my talk. Thank you very much. There's a little bit there with some further reading if those who are interested, but I'll quickly stop so that we've got time for questions.
Thank you so much, Anita and Kokila, both for your talks. I didn't interrupt proceedings because I think it was really comprehensive and really fascinating. Anita, it's a question for both of you, but just to pick up on the opportunities that you went through in your last talk. You know, both of you spoke around the indirect impacts of COVID-19 on surgery, but what do you think is needed in the coming months and years as we kind of go through and hopefully in the end emerge from the pandemic to mitigate some of those indirect effects?
So in terms of women's health, I think we really need to quantify what the effect has been. So, you know, there's the predictions from the Guttmacher Institute, the UNFPA made similar predictions, but we actually need to know on the ground what has happened, not only sort of each country, but also sort of on a regional basis as well, so that we can understand better how to redirect funds, because there's no doubt that you know, we're going to going back in terms of gains that have been made during the Millennium Development Goals, and now with the Sustainable Development Goals, it's going to make them much less likely to be achieved. So getting hard data, I would say, is one of the first things.
If I answer from a pediatric perspective, the Global Initiative for Children's Surgery, we held 2 webinars, one on across the world from our low-income country colleagues to say what was the actual need. And then we had a second webinar 6 weeks later where we had donors and financiers present to say what aspects they would like to fund. And one of the things is that children's surgery has been kind of put aside to cope with the COVID crisis. And now staff need you know, to go through all of these cases. So there's money being put into overtime work and weekend work for low-income country colleagues to get through the work that they're doing.
Thank you both. I'll just take, I'm conscious of time, but there have been a couple of questions from the chat that I'll take. So Kokila, in your introductory few slides, you were talking about the fact that the Oxford University Global Surgery Group is a relatively new network and group. So what do you think, I'm sort of paraphrasing the question slightly, but what do you think have been the opportunities and lessons that you've been able to kind of lean on from other groups, given that your group is newer to the space?
Are you, the question meaning what has happened before the group was established? Is that?
Yes, and in the wider environment of similar networks that are operating in this space, and what opportunities and lessons have you taken forward in how your group's working?
Yes, what we found is one of the most important factor was that we as surgeons shouldn't be working in isolation. You need the teamwork. So Therefore, in Oxford, we have established the 4-department group where anesthesia, surgery, obs and gynae is all interrelated. Because in LMICs, when you do go out into the primary healthcare level or the district general hospital level, you need to be a generalist in the field rather than a specialist. So that was one of the reasons. And even in our work, we now have a team rather than just surgeons collaborating. I think that has been one of the biggest lessons.
Anita, is there anything you wanted to add?
No, I just, yeah, would just second that. So the sort of multidisciplinary aspect is really key to sorting out problems, and particularly in low middle income countries, and this idea that we're all in our little silos doing our own little thing just isn't true if you're seriously wanting to address, you know, these big disparities there are between care. And I think in a way, you know, high income countries have also lost out actually with this sort of super specialization, because there's a lot to gain by having a broader view and by interacting in a sort of multidisciplinary way.
Of course. And then several people have been expressing an interest in how they can join the network, and in particular focused on the training. So what's the best way for them to get in touch with your group or to get involved in your work?
I think we have posted the Twitter group, yes. And also there's on our website, there's numbers that people can contact and emails that people can reach us with.
Great. And for any participants joining, when we share the recording, we can include a link to those spaces as well. But I think we're definitely running out of time, but I'd like to thank you both for your presentations. My apologies to any people that posted your questions, and unfortunately we didn't have time to get to them, but Anita and Kokila, hopefully we can find a way to answer those questions in another forum. And we'll share the recording of the presentation and Heather, my colleague, will just post the link into the chat, so that will be available next week. And we also had a recent lecture that was focused on the gender dimensions of COVID-19, which may kind of lead on from the global health policy and governance perspective from some of the themes that you touched on in your talk, Anita. So if anyone is interested in looking at the recording of that talk, you can also find it on the same page, and the recording of this lecture will be posted there too. So thank you, Anita and Kokila, so much for your time and for your really fascinating presentations. As we said just before everyone joined, we really hope that this will be the start of a series. So we hope for participants that you'll join us again in future. And thank you everyone for your questions. And I'll close the session now, but thank you so much for your time and enjoy the rest of your day.
Thank you. Thanks very much.